There are a number of challenges that the diagnosis of bipolar spectrum disorder can pose, which is precisely why the following information is so essential to mental health professionals as well as patients and their families. Bipolar spectrum disorders are clearly defined within the DSM-IV, or Diagnostic and Statistical Manual of Mental Disorders, and consist of bipolar I disorder, a manic depressive disorder that can exist both with and without psychotic episodes. Bipolar II disorder consists of depressive and manic episodes which alternate and are typically less severe and do not inhibit function. Cyclothymic disorder, a cyclic disorder that causes brief episodes of hypomania and depression. These three conditions together affect approximately 3 to 4% of the population, although recent research and clinical observations seem to indicate that bipolar spectrum disorders may impact a larger percentage of the population to a lesser degree. These patients suffer from a subthreshold bipolar disorder and are often less willing to receive medical therapies such as antidepressants. Continued efforts are being made to properly subtype the bipolar spectrum, but those patients who have subthreshold bipolar disorder are currently diagnosed with bipolar disorder NOS or not otherwise specified. When these individuals are included in the total, the prevalence of bipolar disorder increases to around 5 to 8%. This goes far beyond the mere 1% prevalence currently attributed to manic depressive disorders by major surveys and studies. History of bipolar subtyping. Bipolar disorder was first discussed by German neuropsychiatrist Emil Kraepelin in the late 1800s. He described it as manic depression, and the current DSM-IV subtypes were included in his conceptualization as well as additional variations of episodic depression. Kraepelin's view on bipolar disorder continued until the 60s, when the first DSM was drafted, and the creators proposed a different classification for manic depressive illnesses. In later editions of the DSM, this morphed into what was known as the unipolar-bipolar dichotomy. Types of bipolar defined by Dunner and Feeve. During the 1970s, Dunner and Feeve were responsible for differentiating between bipolar I and bipolar II disorder. In the early 80s, Gerald Klerman went even further by defining the following subtypes: bipolar I, depression and mania; bipolar II, depression and hypomania; bipolar III, cyclothymia; bipolar IV, mania or hypomania caused by antidepressants; bipolar V, genetic bipolar disorder; bipolar VI, non-depressive mania. Today, the leader in the realm of bipolar disorder and subtyping is undoubtedly Hagge Backeskel, a clinical researcher with great respect for Kraepelin and his classification of the bipolar spectrum. His opinion on the subject differs greatly from Klerman, with Backeskel dividing bipolar disorder into 6 primary subtypes which include bipolar I, full mania; bipolar Iowa, depression with hypomania; bipolar II, depression with episodes of hypomania; bipolar IA, cyclothymia; bipolar III, antidepressant-caused hypomania; bipolar IA, depression and/or hypomania caused by substance use; bipolar IV, depression caused by hyperthymic attitude; bipolar V, recurrent depression and dysphoric hypomania episodes; bipolar VI, depression that progresses to a dementia-like disorder. Diagnoses that go beyond the DSM-IV. Any mental health professionals who have dealt with those with bipolar spectrum disorder will certainly agree that there are a number of patients who are suffering from anxiety, depression, and other symptoms that don't exactly fall within the DSM classifications. In most cases, the symptoms experienced by individuals like these are more erratic and change over time. Both depression and anxiety symptoms are atypical, and any present hypomania tends to be more dysphoric than is strictly defined in the DSM. Many patients with these characteristics have been previously prescribed anxiolytic medications or antidepressants by their general practitioner or psychiatrist. They often don't have the desired response to these drugs, with some only experiencing partial relief and others actually regressing into more intense episodes of depression and/or hypomania. Some patients visit a psychiatrist while already taking high-dose benzodiazepine, which oftentimes is unable to relieve their anxiety. All of these patients that seem to defy your typical bipolar diagnosis are lumped into a group that is known as soft bipolars. Until proper subtyping of bipolar spectrum disorders is accepted and used across the board, psychiatrists who are aware of this none-too-rare subgroup are required to go outside of the DSM to diagnose these individuals. Symptoms. There are a number of symptoms that can be attributed to soft bipolar disorder. These include the following: episodes of mood instability. Patients will typically begin to demonstrate mood swings beginning around the time of adolescence. Individuals will alternate between brief periods of depression and euphoria. Paranoia, rage, intense anger, panic attacks, and phobias may also occur. This presence of multiple moods has led many professionals to believe that multipolar is a more accurate term for soft bipolar individuals. Episodes of atypical depression. Patients with soft bipolar disorders will often respond favorably to positive stimulus, but will often return to their overall depressed state within a period of hours to days. Additional symptoms might include binge eating, excessive sleeping, lethargy, as well as anxiety. Seasonal affective disorder, winter-triggered depression, pre- or post-menstrual dysphoric disorder, hysteroid dysphoria typically associated with romantic rejections, and abulic depression are other associated disorders that can go hand in hand with soft bipolar disorder. Hypomania. Hypomania can be either dysphoric or euphoric. Hypomania in individuals with soft bipolar disorder can be either characterologic or episodic, although episodic dysphoria is certainly the most common. Dysphoric hypomania is characterized by irritability, impulsiveness, and poor judgment, while euphoric hypomania can often be pleasant for the individual, causing them to have a temporary boost in productivity and positive emotions. Dysphoric symptoms can be quite damaging to relationships and can often be accompanied by a sense of desperation. Hypomania will often alternate with depression, making the mood of the individual highly unstable in virtually every case. The most common form of hypomania, namely dysphoric hypomania, can often be identified due to the bouts of paranoia, rage, and other emotions that the individual often experiences. Mixed symptoms. Some individuals experience simultaneous hypomania and depression, which is known as mixed bipolar disorder. Others have what is referred to as rapid cycling bipolar disorder, which is characterized by frequent and often unpredictable switches between depression and hypomania. These two forms of bipolar disorder can often confuse the diagnostician and make identifying the problem different for even experienced mental health professionals. These types of symptoms are far more prevalent in women, especially in those who suffer from thyroid conditions, are unresponsive to lithium treatments, or are taking antidepressants that are worsening their symptoms. Diagnosing these conditions in an outpatient setting ranges from difficult to downright impossible, even if a detailed medical history of the patient is obtained. In most cases, a diagnosis of mixed-state disorder are only made after outpatient treatments have failed or only serve to exacerbate the problem. Due to the issues commonly experienced during the diagnosis process, misdiagnosis of mixed-state or rapid cycling bipolar disorder is all too common. The challenges associated with comorbidity. The definition of comorbidity is the simultaneous presence of two or more conditions in one patient. Approximately 50% of individuals with bipolar disorders are comorbid and are living with other psychiatric or medical conditions. Unfortunately, this can often make proper diagnosis and/or treatment more challenging. The following are some conditions that can impact the diagnosis and treatment of bipolar disorder. Thyroid conditions. Both hypothyroidism and hyperthyroidism can complicate bipolar disorders. Since the symptoms associated with hyperthyroidism can emulate those of hypomania, it can both make bipolar disorder difficult to diagnose and the symptoms more pronounced. On the other hand, hypothyroidism can often resemble depression and can make antidepressants ineffectual and worsen symptoms of the disorder. To make matters more complicated, lithium treatments can sometimes cause hypothyroidism, which in turn can impact future treatment. Subclinical hypothyroidism has been linked to the development of rapid cycling and mixed bipolar disorders as well. In order to properly treat the disorder, it's necessary to address the thyroid problem first. In the vast majority of cases, the presence of a thyroid condition will interfere with the treatment of both depression and bipolar disorder. Substance abuse, alcohol and drug abuse are both common among those with bipolar disorder. In fact, about 50% of patients with a bipolar spectrum disorder will struggle with significant substance abuse during their lifetime. This can be a big issue, as addictive and intoxicating substances will almost always worsen symptoms of the disorder. Not only do illicit substances and alcohol impact those with bipolar disorder, but nicotine and excessive caffeine have been known to do so as well. Drugs and alcohol can mimic both hypomania and depression. However, they cannot cause bipolar disorder. However, substance abuse can make an existing illness more obvious, and bipolar disorder can make future alcohol and substance abuse more likely. It's very common for those with bipolar disorder who have yet to be diagnosed and obtain proper treatment to attempt to self-medicate and find relief through a variety of substances, including amphetamines, cocaine, opiates, marijuana, and alcohol. When these individuals finally seek professional care, they often require treatment for two separate conditions that can exacerbate each other. Treatment of bipolar disorder should typically not be begun until the patients have undergone a detox and rehab program and have been free of their substance use for a period of 30 or more days. The symptoms of bipolar disorder will rarely respond to treatment until all intoxicating substances have been eradicated from the body. Fortunately, in many cases, once the detox has occurred and the symptoms of bipolar disorder have been properly treated, the drive that led to the initial substance abuse will be largely dampened. Attention deficit hyperactivity disorder (ADHD). While ADHD is typically associated with small children who struggle to pay proper attention in school, it should be noted that the symptoms of ADHD often carry on into adulthood and can merge with the symptoms typically associated with adults with bipolar spectrum disorder. Both ADHD and bipolar disorder have similar symptoms, such as impulsiveness, poor judgment, difficulty with focusing, restlessness, and hyperactivity. However, bipolar symptoms are rarely constant, whereas symptoms of ADHD are almost always present in one form or another. Both conditions can be present in the same person. However, no one yet knows the frequency of this comorbidity. It's important to identify the cause of the symptoms being experienced, as many treatments used for ADHD, such as Ritalin, methylphenidate, can make the symptoms of bipolar disorder far worse. When ADHD and bipolar disorder are present, tricyclic antidepressants can often be used to treat both conditions. Borderline personality disorder (BPD). Patients with BPD often have symptoms of all of the different personality disorders discussed in the DSM-IV. This can make daily life difficult and unstable. These individuals are often dramatic and prone to feelings of sensitivity and abandonment. They also tend to put far too much pressure on loved ones and often have unrealistic demands for their families and friends. They tend to be self-destructive, and suicidal ideations are not uncommon. It wasn't long ago that those with BPD were believed to be the most challenging of all patients, and many psychiatrists have studied and written about the different methods of treatment. Recently, it has become quite apparent that BPD and bipolar disorder go hand in hand. This determination has been very helpful for patients, as many are now able to receive the treatments they need to stabilize their moods and experience relief. The majority of patients successfully respond to treatment combinations that include SSRI antidepressants, antipsychotics, and mood stabilizers. Once those with a comorbidity of bipolar disorder and BPD are able to stabilize their emotions and moods, psychotherapy has been shown to be much more helpful. Those who accept treatment and are proactive with therapy have a very positive prognosis, especially when compared to the prognosis these same individuals experienced in years past. Other personality disorders. During periods of disturbance, it's common for those with bipolar disorder to experience symptoms of a number of different personality disorders. These can range from dependency, histrionic traits, paranoia, narcissism, hypochondria, passive aggressiveness, and antisocial characteristics. Typically, when the bipolar condition is treated, the symptoms of the various personality disorders will be alleviated as well. However, in cases where the symptoms are severe, treatment can become complicated. Patients who have personality disorders can often be manipulative, self-destructive, and unwilling to seek out the proper treatment. Substance abuse is common, and psychotherapy and pharmacological approaches are often refused. While they understand that the treatment may be beneficial, they often put up barriers and neglect to take the proper proactive steps. It should also be mentioned that bipolar disorders are quite common among those who are incarcerated. Diagnosis. There is rarely any confusion surrounding the diagnosis or bipolar I and II disorders, as the DSM-IV criteria is quite straightforward. However, in cases where depression is the first recognized symptom, it's common for clinicians to withhold diagnosis until a subsequent episode of hypomania or mania occurs. If the depression occurs in episodes and there is a history of bipolar disorder within the family, the clinician should look for other signs of bipolarity such as drug or alcohol abuse, uncontrolled rage, suicidal ideation,